share video. Okay. Good afternoon. So shall we start our lecture now? So I'm Dr. Lisa Au from neurology team, and today we will have 1 hour to go over some basic knowledge on cognitive disorders. So the lecture outline today is we will have an overview first, and then a practical approach to cognitive complaints. And in the end, we will go through the few types of common degenerative dementia. So in terms of statistics, dementia has been a big issue in Hong Kong as well as worldwide because of the aging population. According to the Alzheimer's Disease International figure in 2015, you can see that in 2020, there are already around 50 million people living with dementia in the world, and this figure has been increasing. Estimated to be increasing in the future, as well as especially in the low and middle income countries. And for local statistics, in this report back in 2010, okay, you can see that in the age of 75 to 79, around 9.9% will have dementia, so 1 in 10. And then if you reach the age of 85 or above, the prevalence of dementia further increased to 32%, which is around 1 in 3. This has also caused a lot of healthcare burden. So in public hospital, of course, you can see many patients with dementia. So just like all the other chronic diseases, it's going to be a big burden in hospital as well as in the society. So of course, it's not your not popular singer in your age, okay? But then Lê Khắc Hạnh has a song talking about dementia in a couple of years ago called Sa Wan Gay, and you can just watch it on the YouTube. It's a good MV to understand the symptom of dementia. And the word dementia actually derived from the Latin word demens, okay, with de meaning absence and mentis meaning mind. And so putting these two together, demens, dementia means mad or insane. So it's not a good word, okay. So for the because of the stigma associated with demons, okay? So in the past, we use this dementia, okay, in the past. But then if you have read from psychiatric module, you know that in the updated DSM-5 criteria in 2013, we do not use dementia. We use major neurocognitive disorder or major NCD to replace the word of dementia. And there is a milder stage of dementia known as the mild cognitive impairment or MCI. And in the new updated DSM-5 criteria, it's called mild neurocognitive disorder. Okay, so although this NCD is a new term, but if you read our clinic notes, we sometimes still stick to using these two terms because it's more familiar. So in Chinese, we also have this change in the nomenclature. And in the past, we called it 老人痴呆症, but then it's also causing some sort of stigma. And so it has been at once called 腦退化症. But then 腦退化症 is just degenerative brain disease, which can encompass a wide range of brain disorder, such as motor neuron disease, such as Parkinson's disease, etc. So it's not specific enough. So in the end, in 2012, it was decided that it should be called 認知障礙症. So dementia is now termed 認知障礙症. Okay. So the word dementia is only an umbrella term, okay, to describe a range of conditions causing problems with memory and other thinking abilities. And there are many causes that can lead to dementia. So we can broadly classify them into irreversible causes, or we call this degenerative cause. Another possible causes will be the reversible cause, okay, which is rare, but then we need to exclude these problem before we label the patient to have degenerative dementia. So for reversible causes, what are these causes? You can use these mnemonics to remember, okay, with D is a drug. So there are many drugs that can cause cognitive side effects, such as some sedative drugs, okay, sleeping pills or hypnotics. And also anti-epileptic drugs, okay, is also a common cause for cognitive side effects. For E, it stands for emotional disorder, okay? You have heard of the term pseudo depression, okay? So in a patient who has a severe depression, it can cause psychomotor slowing and also slow response, okay, mimicking dementia. So also there are patients who are anxious with anxiety disorder, okay? They can also cause memory complaint. M stands for metabolic disorder. So includes hypothyroidism, liver renal failure, or B12 folate deficiency. And you can see that in our routine practice, we will order a thyroid function test, renal liver function test, or B12 folate to check for any deficiency. To screen for these metabolic causes, but I would say these are actually quite rare, okay, in clinical practice. E stands for epilepsy, okay. Epilepsy, they don't usually, if the patient presents with generalized tonic-clonic seizure, it won't be missed. But then some patients, they have partial seizures with altered awareness. We call this complex partial seizure. And sometimes the family members were unable to recognize these as an epilepsy. So sometimes it will be misdiagnosed as dementia. N stands for normal pressure hydrocephalus, or NPH. Okay, we will talk about this disease entity later on. T stands for tumor and trauma, okay? Especially in elderly, they sometimes suffer from chronic subdural hemorrhage. CSDH is chronic subdural hemorrhage, okay? They present with cognitive decline without much neurological deficit. So imaging is important. I is infection, okay? In relevant background clinical history. If these infections are suspected, it can be checked, okay? A is autoimmune encephalitis, okay, especially involving the limbic system. We call this limbic encephalitis. It's a new disease entity in the past decade, which can also cause short-term memory impairment. And we will have some case illustration later. So just want to impress you how wide range these patients with cognitive complaint presents to a neurologist, okay? So this is a 62-year-old female, and she was referred by a psychiatrist to our neurology clinic because of dementia symptom, okay? So you can read from the referral letter that the patient has gradual memory decline, forgetful, absent-minded, forgetting repeatedly, and it was causing some functional disturbance because she was a housewife, but she has increased clumsiness to take up this role. There was no mood or other psychotic symptom, and the MMSE is 20, okay, borderline. And so these are common, okay? This is a 60-year-old female, quite young in terms of having degenerative dementia. So you need to be very careful, okay, when you see these sort of symptoms, and don't label the patient directly as having degenerative dementia. So this patient do not have any limb weakness or gait disturbance or headache, but then you can see the CT brain here. So this is the CT brain of the patient. Can you see my cursor actually? If you can't see the cursor, just let me. Oh, okay, good. So this is the axial cut plain CT, which shows that the patient actually has right side temporal lobe meningioma, and it's calcified already. You can see these bright areas. Okay, these are calcified temporal lobe meningioma. It grows from the medial temporal lobe. Okay, so sometimes in these non-motor areas, these patients don't have limb weakness, but it can affect the memory function, and actually in this patient causing recurrent temporal lobe seizure. Okay, so this is one case. Another case is another, I think it's also 60-something male patient. And you can see the referral letter is in 2015, okay? And he had attended a private neurosurgeon because of memory impairment. And you can see that the description is quite peculiar. It's frequent attack of memory impairment, which is unusual, okay? Memory impairment in degenerative dementia usually won't come in bouts of attack, okay? But anyhow, this patient had a private MRI brain in the private sector, and then referred to the public outpatient clinic. But then the outpatient clinic in medicine is quite long, the waiting time. So before seeing medical colleague, the patient 1 year later had a surgical appointment first, and this is a neurosurgical appointment. And then the neurosurgeon in our hospital also writes another referral letter to medicine to advance the appointment. And you can see that the surgeon said that this gentleman had worsening memory and getting lost in streets in 1 year, but he had no TIA or stroke symptom. And then the private MRI brain was unremarkable. And just that the MR angiogram showed there is a mild internal carotid artery stenosis, so clearly early dementia. So the surgeon wrote him another referral letter to medical. And then this was another year. But then still he is not able to advance his medical appointment. And now it's already 2018, okay? 2018, the patient 67-year-old. And what the story goes on is that the patient sought private advice again, and he again was diagnosed having degenerative dementia, and started him on some cognitive enhancer for Alzheimer's disease, known as Aricept, which is donepezil, and Ibiza, which is memantine. We will go through these drugs later on, okay? And then the patient developed drug rash, okay, after these drugs. So another letter from the private to try advance appointment. But then when the patient come to our medical clinic finally in 2018, the patient's wife actually if you dig into the history, the patient's wife reported that the patient had episodic confused behavior and also forgetting the behavior afterwards, but pretty normal in between, okay? And those attacks of memory impairment is actually very short-lived, lasting around like 1 to 2 minutes and then getting gradually better over 15 to 30 minutes. And in the phone capture from the wife. It's a typical features of facial and hand automatism, okay, which signifies the patient has a temporal lobe seizure. So this is the EEG of the patient showing there is frequent sharps over the temporal region. Okay, so the patient was finally diagnosed to have temporal lobe epilepsy and started on anti-epileptic drug, which had stabilized his symptoms. So finally, another patient, also 60-something-year-old female. So this time you can see that the patient has a progressive cognitive functional decline, cannot shower herself, cannot go outside herself, and cannot use MTR. But then also private MRI done already and attended A&E because it's quite rapid decline over a few months. But the MRI was normal, so the patient was quickly actually discharged after 2 days admission into medical ward. But at that admission, the patient already have a little bit of hyponatremia with sodium 130. And so at that time, the case MO think private MRI is normal, and the patient seems to be walking around in the ward without much deficit. Also seems functionally not too much impairment. So just discharged her and plan review in clinic and suspect early dementia. But then after discharge, the patient actually attended a psychiatrist in private, and which also you can see from this referral letter that the patient actually had worsening and serious memory impairment. And she said she took care of her husband, but in fact she has not been seeing him for more than a month because her husband was actually admitted to OH home. So the psychiatrist think it's abnormal. Okay, so attended A&E again and admitted. So the final diagnosis for this patient is that we repeated an MRI brain for her, which this time shows abnormal signal over bilateral hippocampus and mesial temporal region. So this is a case of limbic encephalitis. We also sent her blood for the antibodies, which is known as the voltage-gated potassium channel. It's one of the targets for autoimmune encephalitis. Okay, so this VGKC or voltage-gated potassium channel-related autoimmune encephalitis actually can have a lot of other symptoms apart from amnesia. Some patients will present with seizures or personality change, movement disorder, pain, tumor, neuromyotonia, etc., etc., depending on the target of the antibody. Okay, there are a lot of types of autoimmune encephalitis with different antibodies. This will not be the topic for today. Okay, so just let you know, autoimmune encephalitis can cause cognitive impairment. Another reversible cause will be NPH, normal pressure hydrocephalus. Okay, this disease entity probably will also be covered in neurosurgical module. Okay, it's a disease which is typically consisting of a triad of symptoms, including dementia, gait disturbance, and urinary incontinence. And the gait disturbance is typically the earliest feature of NPH. And the gait is typically like this, described as magnetic, apraxic, and shoveling. Okay. So it's sometimes can mimic Parkinson's gait. Okay, the feet is like sticking to the floor, and the patient will have great difficulty in turning as well as lifting the feet up. Usually on the brain imaging on the right here, okay, you can see there is gross hydrocephalus, okay, enlarged ventricles in patients with NPH. But then if you do lumbar puncture, the ICP is not high. And after shunt surgery, usually the gait will have marked improvement, okay? Just like in this patient after shunt surgery, okay, the gait markedly improve, okay? So this is a surgical cause of dementia. So how do I approach patients with cognitive complaint in clinic? I can tell you cognitive complaint is a very common complaint in clinical practice. So everyone in Hong Kong thinks that their memory is getting worse after the age of 40, okay? And many people in their 60, okay, worried about having dementia. So is there any test that can tell you whether the symptom is related to normal aging or is it related to early Alzheimer's? Unfortunately, there is none at the moment, okay? So the dementia diagnosis at current practice is a clinical diagnosis, which means that as a doctor, you need to analyze all the information from history taking from the patient as well as from the family members. You need to have cognitive tests to have an objective assessment. You need to have blood tests to rule out the reversible metabolic cause, and you need to have brain imaging as well, okay, to rule out structural brain lesion. And then you analyze all the information and then come up with a clinical diagnosis. So for myself, I will ask a few questions, which I think is very important to come up with the correct diagnosis. So firstly, what was the age of the patient? Okay. So if the patient is a pretty young, okay, patient, then I won't jump into the diagnosis of degenerative dementia. So take a good history about any alcohol use, any history of traumatic brain injury, etc. Okay. Of course, in brain imaging, if there is a suspicion of multiple sclerosis, the multiple sclerosis is also a disease that can cause cognitive impairment. And if the patient is in the middle aged, okay, 50 or 60, okay, frontotemporal lobe dementia is also more frequent than Alzheimer's disease sometimes, okay? So you can, later on, we'll go through all the degenerative dementia. But of course, if the patient is an elderly, okay, beyond 70, Alzheimer's disease is still the most common, okay, causes for dementia. The other important question is how was the onset and also the progression. So as I said just now, if the patient has a wax and waning course episodic attack, then think about epilepsy. If the patient had a rapid course within a few weeks or a few days, think about infection or inflammation. If in terms of like few months or within 6 months, also think about CJD, okay? And if the patient had gait disturbance as well as imaging showing hydrocephalus, of course, MPH is another disease that you need to rule out. For degenerative cause, it's usually insidious, okay, over a few years. And then the third question is, what is the predominant cognitive deficit at onset? And you know that the different lobes of our brain have different functions. So temporal lobe, they are mainly for memory, okay, and language. And for the frontal lobe, it's mainly for executive function, planning, organization, as well as behavioral and emotional control, okay? So in different types of dementia or degenerative dementia, they will cause different symptoms because different parts of the brain are affected first. And then the fourth question is, what was the degree of functional decline, okay? So you can ask about the activities of daily living, okay? The basic eating, bathing, toileting, dressing, getting around inside and getting in and out of bed. But then more important, especially in the early stage of the disease, is the instrumental activities of daily living. So these will have problem first before this, okay? So ask about any problem with grocery shopping, money management, taking medication, telephone use, or using public transport, or preparing meals, laundry, or household chores, okay? These are also important clues. And for the DSM-5 criteria for dementia or major neurocognitive disorder, you need to have a significant decline in one or more of the cognitive domains as listed here, including learning and memory, which is the most common, language, executive function, complex attention, perceptual motor function, and social cognition. And it must be at the degree of interfere with independence in everyday activities. It's not due to delirium and is not better explained by another mental disorder. So can we measure cognition? So objectively, can we measure cognition? Unfortunately, we only have some pen and paper tests, okay? So the most common one will be MMSE, Minimum Mental State Examination, or the MoCA. We call this the Montreal Cognitive Assessment. But then these tests have its own limitations, okay? So for MMSE, it's gradually replaced by MoCA in the recent years because MMSE is too simple, okay? And sometimes it's insensitive to mild cognitive impairment, as well as patient who has predominant executive dysfunction rather than memory, okay? As well as it had a severe ceiling effect, especially for those educated people. They learn the test and remember it. And so it cannot be used repeatedly. Also, MMSE had copyright issues in the recent few years, and so in public hospital is now replaced by MoCA. For MoCA, there is a short version, which is called the 5-minute protocol. So it's easier to be carried out without involving writing or drawing, okay? And for MoCA, there is a normative data available locally, okay? Because we found that if we use the single cutoff, such as in 22 in locally or in the foreign countries, 26, we found that we sometimes will overdiagnose patients with cognitive impairment. But then if you adjust the the markings, you compare it with different age groups as well as different levels of years of education. You can see that the number can vary quite a bit. Okay, so sometimes we will compare the patient's number to this table and just to have a better understanding whether the patient is really performing very poorly. But then the score is just a score, okay? The score does not equal to a diagnosis of dementia. So the behavioral observation is important, is whether the patient is engaging well in the test or participating, concentrating in the test is also important. So a low score does not equal to a diagnosis of dementia. And also a high score, okay? Trump scored 30 out of 30 for MoCA, but then it's not an IQ test, okay? Even in a highly educated patient, sometimes even the patient has early disease, the screening test cannot screen out these patients. So the last part would be to go through some of the degenerative dementias, okay? The most common one will be Alzheimer's disease. And Alzheimer's disease is actually discovered back in 1906 by Dr. Alois Alzheimer, who is a psychiatrist and neuropathologist. And the first patient in history with Alzheimer's disease is actually a patient with early onset Alzheimer. So this is a 50-something-year-old lady, okay, who presented to Dr. Alois Alzheimer because of memory decline as well as psychotic behavior, accusing her husband of having affair, extramarital affair, okay? And after the patient died, Dr. Alois Alzheimer performed a brain autopsy on the patient, and found that there is abundant amyloid plaques, which is composed of amyloid beta protein, as well as neurofibrillary tangles composed of tau protein, okay, inside the brain of this patient. And this has been now widely accepted to be the pathological features, okay, of Alzheimer's disease, these amyloid plaques as well as neurofibrillary tangle. Further studies in the subsequent years have shown that in patients who have amyloid plaques, they don't develop the disease immediately. And usually the amyloid plaques will accumulate for at least 10 to 15 years or even up to 20 years before the onset of the symptom of dementia. So it has become clear that the continuum of Alzheimer's disease is actually very wide, okay? So this blue dotted line indicates the time of symptom onset, okay? So if the patient starts to have some memory impairment, but then without major impairment in the activities of daily living, we call this the MCI stage, okay? And then if the patient further progress, then the patient will have overt dementia symptom and require assistance in daily activities. You can see that for the MCI stage, it can persist up to 10 plus years. And then for the dementia stage, from early stage to dementia to severe stage of dementia can be up to 15 plus years. And even before the symptom onset, okay, we call this the preclinical stage. The amyloid plaque can accumulate up to 20 years before symptom onset. So from amyloid beta accumulation to cognitive decline clinically, it's actually a very complicated process involving a lot of other factors. So age, genetics, of course, can interfere with the speed of decline, okay? Other cerebrovascular risk factors such as stroke, and other age-related brain disease such as Parkinson's, okay, they can also accelerate this process. But there are other factors that may slow down this process, such as the brain and cognitive reserve, as well as some environmental factors. So it's a very complicated process to determine. You cannot for 100% sure whether one patient having amyloid accumulation, when will he or she develop cognitive decline? But then this is a graph just to let you know that to detect a patient whether he or she have Alzheimer is getting more complicated with advancing technology. So in the past, we rely on some clinical information as well as some memory testing, okay? If the patient has a deficit in these areas, they will show up as in the test, and we can label the patient is having early Alzheimer's disease, okay? But then in the earlier stage, in the MCI stage, or even in the prodromal stage, we can also now detect these pathological change. In the structural brain imaging, okay, the brain structure can already show some early atrophy on the MRI or CT, okay? And even earlier in the prodromal stage, we can make use of some functional imaging known as a PET scan or a SPECT scan to look for any hypometabolism or hypoperfusion in different lobes of the brain. One step further, even earlier, with the technological advancement, we are actually able to image the amyloid accumulation in the brain, known as amyloid PET brain, okay? So you can see that in the past, we use structural brain imaging to show up the brain atrophy, the progressive brain atrophy in Alzheimer's disease patients. And the atrophy is mainly over the hippocampus as well as the temporal lobe. So on the left side is cognitively normal. In the middle is patient with mild cognitive impairment. And then on the right is patient with overt Alzheimer's disease. But then in the early stage of the disease, we are not able to detect any atrophy on the MRI as of in this slide, okay, on the right. But then we can make use of other functional imaging, such as the FDG PET brain. On the upper panel is a patient with Alzheimer's disease. and the lower panel is a normal control. You can see that on the FDG PET brain, there is already hypometabolism, okay, over the temporal parietal lobe. And then on the amyloid PET scan, we call this the PIP PET scan because the tracer is a PIP, okay, Pittsburgh compound B. You can see there is some red areas, which is the amyloid deposit over the brain. And this is absent in the normal control. Okay. So is there any drug treatment for patients with Alzheimer's disease? There are a few drugs that have been approved in the past 10 years. Okay. You have heard of these before, I suppose. Okay. So two groups. One group is the cholinesterase inhibitors, namely the donepezil, rivastigmine, and galantamine. Another group is the NMDA antagonist. We call this memantine. And for the rivastigmine, apart from oral tablet, it's also called, has a transdermal patch form, okay? But the problem with these Alzheimer's disease drugs is that they do not slow or stop the progress of the disease. It has a limited efficacy and it may cause side effects. Common side effects associated with cholinesterase inhibitor would be diarrhea, vomit, anorexia, and bradycardia. And for NMDA antagonists, they can cause confusion, agitation, as well as drowsiness. So these are the problems with current AD drugs. And the other degenerative dementia is dementia with Lewy bodies, DLB, or sometimes sometimes it's mixed up with another disease called Parkinson's disease dementia, PDD. We'll go through these two. So they have the same pathology, okay? And this is the Lewy body. This Lewy body is composed of a protein called alpha-synuclein protein, okay? And how to differentiate DLB and PDD actually is quite arbitrary, and sometimes even experienced neurologists will make the wrong diagnosis. But then the definite diagnosis will require autopsy, actually, okay? But then the arbitrary rule is that if the Parkinsonism and dementia develop together, then it's likely a case of DLB. But if the patient has Parkinsonism for more than 1 year before the cognitive decline, then it may be a case of PDD. And the difficulty in diagnosing DLB can be illustrated by this real case, okay? Robin Williams, you know him? Do you know him? He's a Hollywood star, okay? A couple of years ago, he committed suicide in his home. And at that time, many people think that he suffers from depression, and that's why he committed suicide. It's not known that actually he suffers from DLB. And how was he diagnosed DLB is because of brain autopsy after his death. His wife actually wrote an article about his husband after his death, okay, and submitted to Neurology Journal. I encourage you to read this journal because it's just written by a layman, okay, written by his wife, and it described the symptoms that his husband has been suffering from, okay? And you can see that from the article that he had been suffering from a wide range of symptoms that seemed unrelated, okay? Constipation, urinary symptom, heartburn, insomnia, and then some anosmia. And he also had a tremor over his left hand, and then rapidly declined to paranoid ideas, delusions as well. So actually, Robin Williams visited a number of specialists without getting the diagnosis of DLB until after his death, okay? So it can be quite difficult. But so the clinical diagnostic criteria for DLB, we usually will ask about these core features: any fluctuating cognition, recurrent well-formed visual hallucinations, Parkinsonism, as well as REM sleep behavioral disorder, okay? These are the common core features of patients with DLB. But they can also have other features such as severe neuroleptic sensitivity. They have falls and syncope. They can have autonomic dysfunction. They have delusions and hallucinations, as well as depression, anxiety, and apathy. So we can see that the diagnosis of DLB can be quite difficult because these symptoms actually can overlap with other disease. For the treatment of DLB, we can use ribostigmine to treat the cognitive symptoms. For the motor symptoms, it's similar to patient with Parkinson's disease. Okay, we use levodopa. And for the behavioral symptom, we use antidepressant or atypical antipsychotics. We usually avoid typical antipsychotics because of the risk of hypersensitivity. Okay, for sleep problems, we use melatonin or clonazepam, and for the autonomic symptoms such as postural hypotension, we use fluorocortisone or midodrine. And for FTD, it's less common, okay, but the onset is actually in the middle age, okay, 50 something to 60. And there are two groups of FTD. One group is the behavioral group, and the other group is the language group known as primary progressive aphasia or PPA. For the behavioral group, we call this BVFTD, okay? The patient will have changes in social conduct and behavior. They will have loss of empathy, apathy, disinhibited behavior, and lack of insight. And these patients sometimes will present to psychiatrists because of these symptoms mimicking some psychiatric disease. For the language group, the PPA group, there are two subtypes. One is the semantic dementia. These patients will have fluent speech, but then they lost the comprehension of the word, okay, the meaning of the word. Then another group is the PNFA, the progressive non-fluent aphasia. These patients will have problem with speech production. They will have advertful speech. They will have apraxic speech, okay, but then the comprehension is usually preserved in the early stage. And they have different patterns of brain atrophy for these three types of FTD. Usually for patients with language variants, they will have left-sided brain atrophy first. So it's difficult to let you know the symptom of these patients. Just let you watch the video. Maybe it's easier to grasp what is FTD. So this is a patient with a BV-FTD.
And we were seeing our son disappear before our eyes, little bit by little bit.
Sue and Bill Bishop are watching a disease called frontotemporal dementia, or FTD, consume their son Brad. The brain disorder with no cure is changing him from a caring young man with a bright future into a person whose behavior is erratic, childlike, and at times inappropriate.
Who is it?
I don't know, let's check.
Who is it?
I'll have to see who's calling.
Who is it?
It's not Brad. It's Brad's body. Of course, even that's different.
Brad's first symptoms were subtle personality changes. He'd forget to return phone calls and emails. He'd act childlike in public, and he grew self-centered, a trait his parents say was completely out of character. And as the disease progressed, symptoms got much worse. Brad became agitated around people, and he couldn't control the urge to eat.
So we literally had to put locks around the fridge and freezer.
For more than a year, doctors did not know why this was happening.
Okay, so you can have some idea of patient with behavioral variant FTD. They have a personality change. They have disinhibited behavior. They have hyperorality, etc. Okay. And the other variant is the language variant, okay? So you can see from this very old video of a patient who had semantic dementia. They keep talking and talking, but quite irrelevant.
Right. Oh my Lord, I thought, bang, 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 bang. And I thought, oh my God, oh my. And I thought, I'll be darned, it's all right.
Who fixes it for you?
D.
D. Who's she?
Millie. And I saw she
Who's
said,
Millie?
Millie.
Who's Millie?
Millie.
I don't know Millie.
Oh no, she's gone. She's gone like that.
Mm-hmm.
And Millie and Carol. And no, Carol and Millie.
Are those your daughters?
No, oh yeah.
I know Carol's your daughter. Millie also?
And I thought, oh boy. And I thought, oh my God, and I thought like this, oh, Hoppy T.
She does a nice job.
Yeah. And I thought, oh, Hoppy darn.
Okay, so it's just another patient who had another subtype of language variant. Okay, it's a progressive.
I used to do presentations and talk to the staff. At times, that's all gone.
Okay, so you can see the different symptoms. Okay, and another thing that I want to let you know is that in patients with FTD, they don't just have cognitive or behavioral decline. They also have coexisting motor problems, usually around 30 to 50%. So they can overlap with motor neuron disease, as well as some atypical Parkinsonian syndrome, including progressive supranuclear palsy or cortical basal syndrome. Okay, they have these overlapping disease. Because if you go further into the pathogenesis or the genetic causes, actually these FTD has overlapping pathology with ALS, amyotrophic lateral sclerosis, as well as PSP and CBD. And they have these TDP43 or FUS or tau protein accumulating in the brain, giving these wide range of symptoms. And they have underlying different mutations that you don't need to know these, okay? So the treatment of FTD is none, okay? There is no medication that can treat this disease. It's mainly focused on symptom control, such as SSRI for behavioral problems. So last but not least is VAD, okay, vascular dementia, and also a common cause of dementia in elderly. So the diagnosis of vascular dementia will require, of course, dementia symptom as well as evidence of cerebral vascular disease, be it a history of stroke or focal signs of examination or brain imaging showing that there is cerebral vascular disease. And there is also a wide range of different types of vascular dementia. And I think the common ones that you have heard will be multi-infarct dementia. So patient admitted to acute stroke unit after stroke and then with cognitive impairment, or a series of infarcts or a series of stroke events, okay, causing a stepwise cognitive decline. But there are also patients who have only a small stroke, okay, such as in this bilateral thalamic infarct, okay, only a small infarct, but then the patient had a marked cognitive decline without much motor impairment, okay, still walking around, but then marked cognitive decline after a strategic stroke. We call this strategic infarct dementia. So in some patients, they have insidious onset of cognitive decline, and with brain imaging showing in these flare images or confluent white matter changes with these white areas, okay? These patients we in the past called Binswanger's disease, okay? We call this subcortical vascular dementia, and these can be difficult to differentiate from Alzheimer's disease actually, because they both present with insidious onset of cognitive decline. But for a patient with pure subcortical vascular dementia, they usually have a predominant executive dysfunction rather than short-term memory impairment. So there are other rare causes, such as genetic cause. In this patient, for example, okay, with a disease known as CADASIL. CADASIL is actually stand for a long-term, okay, cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy, okay? It's an autosomal dominant disease and it's due to a mutation in the NOTCH3 gene. And these patients, they usually present as stroke at middle age without any vascular risk factors, okay, like in the age of 40 to 50. And they usually will have migraine in their teenage, and later on they will have mood disturbance, apathy, as well as dementia. Okay, on brain imaging, typically they will have extensive white matter changes, and typically also involving the anterior temporal lobe. Okay. And other vascular disease is cerebral amyloid angiopathy. So this is not infarct, okay? This is hemorrhage, okay? These CAA, cerebral amyloid angiopathy, is due to cerebrovascular amyloid deposition, and it's an important cause of lobar intracranial hemorrhage in elderly who has no hypertension. And it's also a disease that has a close association with Alzheimer's disease. And the treatment for vascular dementia is to control vascular risk factors, okay, to prevent stroke. And there is no single pharmacological treatment that is concluded to be effective for vascular dementia. But then in the end, is that this is just to let you know that it's not so simple, okay? So not all patients had single pathology. So in most of the patients that we encounter, especially in elderly, they have mixed dementia, which means that they have amyloid and tau in their brain, but they also have abundant vascular lesions in their brain. And usually we call this mixed dementia, so Alzheimer's plus vascular. Of course, there are other disease entities such as the DLB, which is due to alpha-synuclein, and FTD, which is predominantly due to DTP43. Okay, so I think I have gone through, I hope I have gone through all the cognitive disorder in 1 hour, which is difficult, but I welcome some questions. If you do have questions, you can raise it up in the chat box. Or if you cannot think of any question, you can email me later on. Okay, so if you have questions, you can email me later on, or I'll just stop sharing this screen, okay? About the Alzheimer's drug, so one student have a question about the Alzheimer's drug. What are they useful for? Controlling behavioral symptoms. Okay, so the Alzheimer's drugs, they are usually prescribed for cognitive symptoms, but then there are some study trial also showing that it, especially for memantine, they can reduce some of the behavioral symptoms, but they are mainly used for cognitive symptoms. How can we differentiate? There is another question. How can we differentiate dysarthria and apraxic speech? Okay, dysarthria is patient is actually speaking fluently but cannot articulate clearly. Apraxic speech is slow in speech and production. Yes. Okay, if you have no further question, we'll end the lecture here now. Okay. Bye-bye.